Olá, eu sou Mariana Varela e hoje estou aqui com Sir Michael Marmot, que é diretor do Instituto de Equidade em Saúde e professor de epidemiologia na University College London desde 1985. Além de autor de vários livros, como The Health Gap, The Challenge of an Unequal World, numa tradução livre, A Desigualdade na Saúde, o Desafio de um Mundo Desigual. Marmot é uma das maiores autoridades mundiais no estudo da influência dos determinantes sociais que impactam a saúde dos indivíduos. Ele esteve no Brasil por ocasião do lançamento do Conselho Global sobre Desigualdades e Pandemias. Ele gentilmente nos concedeu uma entrevista breve em que pude ouvir mais sobre como a desigualdade socioeconômica afeta a saúde, sobretudo no que diz respeito às pandemias como a de Covid-19 e HIV. O senhor estuda a associação entre saúde e determinantes sociais como fatores demográficos, nível socioeconômico e raça. O senhor poderia explicar como esses fatores afetam a saúde?
I first started looking at health of migrants. I was involved in a study of men of Japanese ancestry living in Japan, Hawaii, and California. And as they migrate across the Pacific, the rate of heart disease goes up and the rate of stroke goes down. It's clearly related to the environment in which people live. And in fact, my PhD thesis looked at aspects of Japanese social life and showed they were protective against heart disease among the Japanese living in California. And then in Britain, my studies in the Whitehall study showed that the lower the position in the social hierarchy, the shorter the life expectancy and the higher the mortality rate. And it was a social gradient. The lower the position, the higher the mortality. And it ran all the way from top to bottom. People say, well, these are public servants. Would that apply to the country as a whole in Britain? So we classified people by where they lived, classified where they lived by degree of deprivation, and again showed a gradient for the whole country. The more deprived the area, the shorter the life expectancy. And that finding of a social gradient has been reproduced all around the world. In southern Brazil, for example, in Porto Alegre, in Rio Grande do Sul, the more deprived the area, the higher mortality. That social gradient's been reproduced all around the world. The second kind of observation of inequalities are the inequalities between countries. When I was first looking at this in the 1980s, there was a 40-year gap in life expectancy between the countries in sub-Saharan Africa with the shortest life expectancy and Japan with the longest. Now that gap, that inequality, that global inequality was huge, but within the Scottish city of Glasgow, men in the poorest part of Glasgow had life expectancy 28 years shorter than men in the richest part of Glasgow. In other words, the inequalities within countries in health were nearly as big as the inequalities between countries. And a big question is there a common set of explanations for these observations of within country inequalities and between country inequalities?
O senhor estuda esse assunto há mais de 30 anos. O senhor tem visto alguma mudança positiva no sentido de reduzir as disparidades no acesso à saúde em nível global?
Well, firstly, let me make clear that I'm talking about health, not access to health care.
Okay.
Most of the inequalities in health that we see are not the result of inequalities in access to health care. So universal health care, health coverage, is vitally important. But that's not what I'm talking about. I'm talking about the social determinants of health. Now, we have seen very real and very welcome reduction of inequalities globally. So, for example, look at under 5 mortality rates. The African region had the highest under 5 mortality rates, still does, but the improvement in the African region has been much bigger in absolute terms than in the other regions. So the gap between countries in the African region and in other regions has got smaller. That's amazing. When we look within countries, again, let me take an example from Latin America. In Peru, if you look at mortality in children by the level of education of the mother, there's a very clear social gradient. The more education the mother has, the lower the child mortality. And that gap between mothers with little education and mothers with higher education, that gap over a 20-year period has got smaller. So very welcome. We've got examples of improvement in inequalities between and within countries. On the other hand, we also have examples where the inequalities are getting bigger. In my own country, in the United Kingdom, for example, after around 2010, the social gradient got steeper, the inequalities got bigger, and life expectancy for people in the most deprived areas actually went down. So not only did we see inequalities get bigger, but we saw health for the poorest people getting worse. And you might well ask, what happened in 2010 that might have caused this? We had a new government elected, and the principal aim of this government was austerity, cutting back on public expenditure. They cut back on public expenditure, and health stopped improving, health inequalities got worse, and health for the poorest people went down.
Apesar da incidência de HIV estar diminuindo no Brasil, houve um aumento na incidência entre jovens e negros na última década. Por que o senhor acha que isso acontece?
Let me talk about pandemics generally, of which HIV/AIDS is an example. What we saw with the COVID-19 pandemic was an exaggeration of firstly, an exposure of the underlying inequalities and an amplification of them. So what we saw was that the lower the socioeconomic level, the higher the mortality from COVID. We saw a social gradient in country after country. And if anything, that social gradient got steeper. The inequalities got bigger. So the pandemic revealed the underlying inequalities and amplified them. And the figures you've just quoted for Brazil and HIV is an example of that. What the HIV/AIDS pandemic exposed the underlying inequalities and amplified them. So for white people in Brazil, things were getting better. For black people, things were not getting better, getting worse. And the general approach that we've taken to try and understand this was laid out. I chaired the World Health Organization Commission on Social Determinants of Health. And we said that inequities in power, money, and resources drive inequities in the conditions of daily life, the conditions in which people are born, grow, live, work, and age. And those in turn are responsible for the inequities that we see in health. And what you've just cited is an example from Brazil for a specific condition where we see these racial ethnic differences.
A pandemia de Covid nos mostrou que os determinantes sociais causam impacto não apenas no acesso à saúde, mas também nos resultados da falta de saúde. Como o senhor entende? O que o senhor acha que a gente poderia ter aprendido disso para se preparar melhor para outra crise de saúde global?
Pandemics expose the underlying inequalities in society and amplify them, so that the social determinants of health and inequalities in the conditions in which people live actually make pandemics more likely, and the pandemic then exposes and amplifies those inequalities. And we see it not just with pandemics, you see it with a tsunami, you see it with a hurricane.
Yeah.
In Puerto Rico, when Hurricane Maria hit, the mortality was highest in people of low socioeconomic level. It was intermediate in people of intermediate socioeconomic level, and the mortality was lowest in people of high socioeconomic level. So you see that a pandemic, like any other big external shock, affects people differently depending on their social and economic position. And with COVID, you could see it when countries were moving to lockdown. People in frontline occupations couldn't be locked down. They were being exposed to the virus. If you were collecting rubbish, if you were a delivery driver, if you were working in a shop, quite apart from being a doctor or a nurse, if you were in a frontline occupation, you were being exposed to the virus. If you were in crowded living conditions, you were more likely to be exposed to the virus. And then, where countries did lock down, people in lower socioeconomic positions were less able to work from home. So they were either being exposed to the virus or losing their jobs and losing their economic livelihood. And richer people who could work from home, they kept their income. In fact, in many cases, their income went up because they couldn't spend money. They couldn't go out to restaurants because the restaurants weren't open. So the people who serve in the restaurants were out of a job and getting poorer, and the people who would otherwise go to restaurants were getting richer because they couldn't spend their money.
A pandemia de Covid nos mostrou que até os países ricos não estavam preparados para enfrentar uma crise de saúde dessa magnitude. O que o senhor acha que a gente poderia ter feito melhor para nos prepararmos e respondermos à pandemia de Covid?
There's several things that we could have done better. The first is global cooperation. We know that I've said that the main issue is not access to healthcare. That said, the vaccine for COVID makes a difference. And we know that the rich countries used the vaccines that were developed remarkably quickly, and much less of the vaccine was made available to low and middle income countries. We know that in the rich countries, when they were closing down their economies, it was going to lead to real economic crisis. So the central banks in the rich countries got involved, and the government treasuries. Among the rich countries, by the end of 2020, they had issued $18 trillion of new debt. $18 trillion, $18,000 billion of new debt. The cost of global rollout of the vaccine would have been about 25 billion. So that's coffee money. That's nothing at all. If you're issuing $18 trillion of new debt to save the economies of the rich countries, you could find 25 billion for global rollout of the vaccine. So that kind of global cooperation is important. The second clear lesson, I think, already before our Global Council meets, is that the supposed trade-off between public health and the economy is false. Mm-hmm. Some governments were saying we can't take the steps to lock down because it'll damage the economy. We've got to keep the economy open. In fact, if you look, the countries that controlled the pandemic better had a smaller hit to their economy. In fact, the two go together. There's not one against the other. The two go together. Do the right public health measures, control the pandemic, and you get less of an economic hit. And a third major lesson is to address the inequalities and to be prepared. And if you've got grossly unequal societies with big inequalities in health, you are not well prepared for a pandemic.
O Brasil é um país extremamente desigual e isso impacta o acesso à saúde. Na sua opinião, o quão importantes são os determinantes sociais para as políticas públicas de saúde no Brasil?
I think social determinants of health are crucial for Brazil, as they are for all other countries. So access to healthcare is, of course, vitally important. But we know from the cash transfer studies in Brazil, from Bolsa Familia, that if you give poor families money, cash, the health of mothers and babies improve. Actually, making poor people less poor is really rather important. Summarizing the findings and recommendations from the Global WHO Commission, when I summarized them for the United Kingdom, I think nevertheless they apply to Brazil. And I had initially 6 areas of recommendations. Number 1, give every child the best start in life. Well, that certainly applies to Brazil. Number 2, education. Everyone should have access not just to primary education, but secondary education and increasingly tertiary. And we know in Brazil, the lower your income, the less likely you are to get tertiary education. It's vital to break that barrier. Number 3, employment and working conditions, vital for health. Number 4, having enough money to lead a healthy life. Number 5, healthy and sustainable places in which to live and work, including housing. And number 6, paying attention to healthy lifestyle, but recognizing the social determinants of smoking, of drinking, of being overweight or undernourished and the like. I think they all apply to Brazil, and I've added 2, which I also think apply to Brazil. Tackle racism, discrimination, and their consequences. And number 8, pursue the tackling of the climate emergency and health inequities at the same time.
A saúde é um dos direitos humanos, mas as desigualdades fazem com que milhões de pessoas não tenham acesso à saúde. Na sua opinião, o que pode ser feito para aumentar e melhorar o acesso à saúde?
I would say that we need 3 things. 1, the knowledge, and I think we have a great deal of knowledge, and our new Global Council will see as its task bringing that knowledge to bear on policy. Secondly, you need the resources. There's a lot of money sloshing about the world. A lot of people got very rich during the COVID pandemic. In fact, the wealth of billionaires went up dramatically during the COVID pandemic. A lot of billionaires have got richer because of the war in Ukraine. The energy companies are getting fantastically rich. In Europe, the cost of living crisis with the increase in food prices have led to enormous profits from companies. So the resources exist. It's the distribution of those resources that are key. So the first is the knowledge, the second is the resources, and I think we have quite a lot of both of those. The third is political will, is what we want to do with the knowledge and of those resources? Do we have the will? Well, these are big, complicated questions. What I've just been seeing the last 2 days in Brazil is a real expression of political will to make a difference. These are big, complicated questions, and I'm not expert in Brazilian politics, so I can't pretend to any special insight. But I've certainly seen the expression of political will over the last couple of days really to make a difference. Now, we need that globally, and that's tricky because the decline in democracies around the world is alarming and troubling. Hitherto healthy, robust democracies have become less healthy and less robust. We saw it in Brazil. We see it in some European countries. We see it in the United States. In France, Marine Le Pen got, 47% of the vote, I think. The extreme right-wing party. So we're seeing it in many countries, which is really troubling. In the past, when countries, sometimes they would have a right of centre government, sometimes they would have a left of centre government, fine. There's a general view about the common good. We're seeing a retreat from that to the extreme right, less of the extreme left at the moment. But that's a very troubling development.
Yeah, also here in Brazil, right?
I was told yesterday by a Brazilian colleague that the Congress took a move yesterday or very recently to undermine attention to indigenous people in Brazil.
Yeah.
That's a backward step. So it's not straightforward.
Você poderia nos falar um pouquinho mais sobre os objetivos do Conselho Global sobre desigualdade, AIDS e pandemias?
Well, we'll have 3 co-chairs. I'm one of them. Joe Stiglitz, who's a Nobel Prize-winning economist from Columbia University in New York, and the First Lady of Namibia, Madam Gengos, will be, and she's a human rights lawyer. So human rights, economics, social determinants of health, and President Lula will be an honorary co-chair of our council, which is a really interesting development. And we want to try and act as quickly as we can. I've chaired other commissions where it takes us a couple of years, we gather evidence, we produce a big report at the end of 2 years. What we want to do is act more quickly. We want to become part of the conversation of what you and I have been discussing, how social and economic inequalities drive pandemics, and how pandemics increase social and economic inequalities, and what to do about it. So we want to bring the evidence to bear on how all that works with sets of recommendations. And we want to be part of the deliberation within countries and global deliberations of what needs to be done. So your question to me, what are the lessons that we can learn from the COVID pandemic and indeed from the AIDS pandemic, is exactly the mission of our Global Council. What are the lessons we can learn and how can we work to prevent pandemics having the same devastating impact in the future?
Nosso tempo está acabando. O senhor gostaria de dividir com a gente suas considerações finais?
Yeah, I'm excited. I want to tell you why I'm excited. Commonly, I get asked, look, you chaired this WHO Commission on Social Determinants of Health. You reported in 2008. You did the Marmot Review in England, 2010. You've done regional commissions on social determinants in Europe, in the Americas, in North Africa and the Middle East, and no one's listening. Aren't you frustrated? And my response is the opposite. I have evidence-based hopefulness because people are listening. What I heard in Brazil yesterday of this new interministerial committee on disease control, really exciting. This global council, really exciting. It means UNAIDS came to me not because I'm an AIDS expert, but because UNAIDS, who are the AIDS experts, want to bring understanding human rights, economics, social determinants of health to bear on AIDS and other pandemics. So it's really exciting. When I go back to the UK on Monday, I will travel up to the English city of Leeds because it's going to become a Marmot city. We have Marmot cities all around the UK. They've taken my recommendations and they're implementing them. So my final thought is we are making progress. People are listening and they're trying to act on it. It's difficult. There are countervailing forces. I'm not a cockeyed optimist. I don't think everything's beautiful, but by golly, we are making progress.
Thank you, sir, thank you for the interview. It was a pleasure to have you here with us today. Thank you very much.
Thank you very much.